Italian Heritage Month, and the Columbus Day Parade is on Monday, and I'll be in it, and a lot of others of us, the Casa Italia volunteers, will be in the parade. But it's great to celebrate Columbus, but I celebrate, and I think we at Casa Italia do, we celebrate our immigrants, or what Italians have contributed to America. Well, Columbus discovered it. Well, they say we built it, and we cured it. So the guy we have today is a real hero in our community, and he deserves all the accolades he could get. There was an accolade given to him 10 or 15 years ago by the Joint Civic Committee, which we should do every year, I think. But we did a video of him. I don't know if any of you have seen the video that is on YouTube. He discusses his career and his life and his work. But Dr. Enrico Benedetti is one of our most successful achievers of Italians who migrated to Chicago. And so learning his story is going to be a real treat for us today. And I've been looking forward to this event for a long time. And he tells me that this is the first time that he's talked about himself in a presentation at any length. So you're going to hear the whole story from him today, from the doctor's mouth, and we will be the better for it. We'll be ennobled for it. This success in America, I think, is what we all like to believe is the essence of America. The freedom to come and create and to be our best selves possible. And so, without any further ado, listen to me, Dr. Enrico Benedetti. All right. You tell me when it is.
All right. Well, good morning. He's right. It's the first time that I accept to talk about myself in public. I'm not a very public person. I like to keep things for myself. But I couldn't say no to Dominic. It's been always so nice to me and so important to the Italian community in Chicago. So, and the title is his title. Reception of Italian medical immigrant in the US, please. It started in this ancient Tuscan city, Perugia, where I was born many years ago in 1960. It's a beautiful city that was actually Etruscan, but it was not my city. My mother got sick, so they took us to the main hospital of the city. And my real hometown, is actually Gubbio. Gubbio is actually an Umbrian city. It's only 30 miles from Perugia, but it's a completely different culture. That's the ancient Umbrian, one of the first people to actually inhabit Italy. And as you can see, it's a medieval city on the side of the mountain, Monte Sant'Ubaldo, but on the plain is Roman. That's typical transition from Roman time, when they didn't have to defend the city, since Rome was ruling the known world, and medieval time, where actually they had to defend themselves from the next door city. The reason why they have such a beautiful, it's an amphitheater, is because when Gaius Julius Caesar in January 49 invaded Italy with a single legion at 13, he sent 3 cohorts, so each cohort is 1,500 men, to Gubbio that was held for the Republican by a very large group of military. And Gubbio opened up the door and kick out the Republican side with Caesar. So, of course, the Julio-Claudian dynasty, the first imperial dynasty, took care of Gubbio, and they give this beautiful amphitheater. It's one of the largest in Italy and still used for plays. Gubbio is an interesting city, very segregated. So I grew up mostly in the countryside, and that's why probably I wanted to be in a city. So, the city, please go on. This is actually our Palazzo dei Consoli. In the 12th century, Gubbio had nearly 50,000 inhabitants, as much as London. Of course, we never reached this degree of power and well-being. There are less people now than in the 12th century. Next. I choose to actually go for my study in Florence, which is maybe under 50 miles from home. Metropolitan city, beautiful, international. Everybody loved this city, and one of the great emotions of my life, the first time I saw this statue, that I think is just breathtaking, the David Michelangelo. So the University of Florence has an interesting history, like many places in Italy. It was founded in 1321. It's called Studium Generale. And one of the first professors, Giovanni Boccaccio, who did a series of lectures on Dante, Divina Commedia. When Emperor Charles IV is the emperor that made Prague famous. So Charles of Luxembourg, he came to Tuscany. He founded a city called Monte Carlo, not to be confused with the most famous one, and granted to the city of Florence the title of Imperial University. So everything seems to be well started. But that's a typical Italian policy. In 1473, Lorenzo the Magnificent transferred the university to Pisa. That's a strange decision, right? The dynasty that supported the Renaissance that doesn't want the university in town. Of course, university means student means disorder. The Medici had a relation of love and hate with Florence, right? Because they were kicked out by the Florentine at least twice. So he moved to Pisa, and the university remained in Pisa, except a short period when they kicked out the Medici, until 1859. So there was no university in Florence for all this time. It was in Pisa, a smaller city on the coast. Until the last Granduca di Toscana, Leopold II, was exiled, and then finally they reopened in 1859 for college, including medicine. Now, 1859 is pretty late, because as you know, Italy has been, I must admit, the place where university study was started. So the first university in the world with continuous operation is the University of Bologna, which was founded in 1088. The French will start to tell you that the first medical school is Montpellier, which was founded in 1276, but it's not true. It's the University of Padua. It was actually easy to remember, 1222. So Italy has been really the cradle of university education. So Florence came late, but it was a great university, very difficult. I did my 6 years in medicine between 79 and 85. And then I stayed on in Florence to do a full surgical residency. So I was completed by 1989. I had also the surgical degree. And why did I choose to leave Florence? I get this question a lot, right? It's a man. I had no intention to leave Italy. He's a professor of surgery that I was working for the University of Florence. A cruel man and dangerous. That unfortunately I witnessed doing really bad things to patients, to the point that I took a clear-cut opposition on his. I throw away my gown, I walk out, and of course that's not good for your career in the University of Florence. So the next day I decided to actually study for the test that was called ECFMG. It's an exam that would allow my medical degree to be recognized also in the US. And I was a good student. I passed a 99 percentile worldwide. So I figured they're gonna fight over me, right? So I applied in 1987 for surgery, and I sent my application to 110 US programs, of which 106 never bothered to respond, and 4 said no. So there is always an obstacle for a foreigner that wants to come to the US. That's is true now as then. So it's very difficult for a foreign graduate to get into the American medical system. But the interesting part is that if you get in, you have no handicap. The fact that you're a foreigner, if you are in the system, it doesn't present an handicap. It's a completely meritocratic system. And I'm not living proof. I came here without even speaking the language. When I did my interview for the resident, I memorized 25 commonly asked questions in surgical interviews, and I give the impression that I knew English. So, I'm back. This is the man that allowed me in, Professor Lloyd News. He was the chairman of the University of Illinois in 1988, and thanks to him, which I reached through a long sequel of people, I was accepted at the University of Illinois. Now, University of Illinois in 1989, some of you may remember, there was a decision of the state to close down the university hospital and transfer everything to Michael Reese. A group of doctors actually didn't let it happen, which was good because now Michael Reese is closed, we are still open. That year, in 1989, University of Illinois was not as appealing to American students as it is now. Last year, for 7 positions, we had 2,000 applications. But back then, Americans didn't want to go. And I saw my opportunity. I knew that the state university couldn't be bad, right? In fact, the university bounced back better than America. And this is the man that let me in. So in 1989, I came to Chicago to start my surgical residence at the University of Illinois. And back then, we were covering Stroger, or Cook County Hospital back then. So I'm sort of proud to tell you that although we stopped the relation with Stroger that moved to Rush in 1994, this year we took him back. So this year, the University of Illinois Department of Surgery is controlling that residency. And we are actually a single program with them. I'm very proud. But you see, when I came to Chicago, as I said, I didn't speak much English. I learned my English in that building. Then now it's a luxury hotel, but back then was a dangerous building, right? People getting stabbed, etc. So I spent 7 months of my year at the Cook County Hospital, and it was not an easy training. No, they now have what is called 80 hours a week, meaning the resident cannot work more than 80 hours, they need to go back home after a night on call. We didn't have that. We were every night call, which means you start at 5 a.m., you work all day, all night, all day. You go home at 7, 8 p.m., and then you start at 5. Not for 1 month, not for 2 months, like 8 months at a time. The weekend, we lived in the hospital, so we were on call from Friday until Monday, and then maybe we were on call again. So it was a tough training. Back then there was a big trauma unit at county. Now it's no longer the biggest one. The biggest one is at the University of Chicago because of their location. But back then we had, 12, 15 penetrating injury per night. In a month as chief resident at Cook County, I did 125 penetrating trauma, chest and abdomen. It was a war. It was a war much worse than now. To give you an idea, back then there were about 1,100 deaths. Now there are maybe 500 and going down. After I finished the University of Illinois, I moved to Minnesota, and I did the residency fast, in 3.5 years, because they recognized my Italian training. That's me as the fellow. There's still this picture in the hallway of the University of Minnesota. University of Minnesota back then was truly a temple of transplant surgery. Pancreas transplant was invented there. transplanting diabetic was done there for the first time, islet transplant, everything was actually started in University of Minnesota.
Thank you.
I moved back to Chicago in September '94. I was offered a job at the University of Minnesota. They made a very favorable offer for me to go to Bismarck, Dakota. They offered me like 5 times the salary that they offered me in Chicago, because of course nobody wants to go, but I choose to go back to Chicago. I always liked this city. So, and I went back to the university. They gave me the opportunity to train. So in September 1994, I came back as assistant professor in the division of transplant. Immediately, my colleague quit the day that I start. So in total, I did 5 years consecutive without vacation.
Wow.
Because to accelerate the course, I accept not to take vacation during my residence, my fellowship. And then for a year, I couldn't do even when I wasn't attending. But it was worth it because I accelerated the process. And then at the University of Illinois, I had a good career. I was already chief of transplant in '98, associate professor 98, full professor 205. In 2006, actually, I became the head of the Department of Surgery. That's a fast career that nowhere else you can do it. It's not like even the most talented American goes to Florence. He's going to become department head. No way. No way. It would be an Italian operation. But the US is more difficult to have the option to enter the system. If you enter the system, it's a fair game. I've never seen first-person episode of nepotism, except one time. I won't talk about that. So I had a good career. I wrote 400 articles, 32 book chapter. I have a couple of books. So I did well. And I have a few people to thank because they give me the direction. Dr. John Nigerian, which is a legendary transplant surgeon, was the chair of surgery at the University of Minnesota. He really explained to me how to run a program, how to be successful as an administrator, and how to invest in research. Dr. Nigerian was a formidable man. And Bill Payne, who was the chief of liver transplant at the University of Minnesota, is my mentor for technique. He was a formidable technical surgeon. I learned a lot from him. And I must tell you that although I published some paper, I made my career in the operating room by operating. And I learned from that man, Bill Payne. And then the picture lower is Dr. Das Gupta. He was a famous surgical oncologist in Chicago. He's a man that for 35 consecutive years had NIH funding, the greatest source of funding in the US. And every year was doing 400 to 500 cancer cases. Master surgeon, great educator, and great academician. The triple threat, they call it. You know, whenever somebody's good in everything, is rare. He's the only man that I recognize that particular skill. Dr. Das Gupta took me aside when I was a very young doctor in '94. And he told me, he always liked me. He told me, Enrico, I know that you like to operate everything, because I was doing everything, you know, liver, pancreas, stuff, whatever came my way, I did it. Although I was a transplant surgeon. He said, but remember my word, if you want to become somebody in the academic world, you need to select a topic. It doesn't matter if it's a very small, limited topic, but in that topic, you must become the world authority. When they talk about that topic, they need to invite you. If they write an article on that topic, they need to consult you. That's what he told me. So I started thinking, what can I do that is original? And I focus on small bowel transplantation from living donor. Now, just to give you an idea, this is an unusual operation. The University of Illinois still has the only program active in Michigan, Wisconsin, Illinois, and I'm still the director. So we do maybe 5 cases a year. You might say that's not much. Well, the total number of cases done in 2024 was 44 for the country. So it's an unusual set of skills. And we start doing actually the transplant from living donor. At the time, the result of cadaver was not very good because of rejection. We thought using living donor would do better. And in fact, we did actually the total of 30 cases out of 43 ever done in the US. So that was a small field, but clearly we were not the leader, right? Oh, you don't need to show the video, go on. Go on. So for example, take these two twins. Those are the Ricotta brothers. They're from New Jersey, right? So the sick one is the one on the right side. What he had a rare disease that caused him to lose the entire small bowel. So they call me from New Jersey after I've done already a couple of these cases and say, I have an identical twin. Would you do the transplant? Of course, if you do it from an identical twin, there's no risk because there's no rejection. And so the Ricotta brothers are still doing well after 25 years, something.
Wow.
This is another set of identical twins, you see. And this one, the one to the left is the person that had multiple gunshot wound to the abdomen. Nice man, fully employed, just passing by the wrong neighborhood at the wrong time. And we rescue him, and then his identical twin give the living donor bowel, and still the two are doing great. So it's a good thing. It's more difficult technically, but of course in certain circumstances superior. So I do it only if I have a perfect match nowadays, because there's so many cadaver organs and so forth. But you see, we beat this is an international registry called ITR, and our adult living donor survival, as you can see, beat all the era. There are different era. Now the lower one is at the beginning and then more and more common, but we did well. And then we moved on to children. Children that back then the situation was radically different. Children with short bowel tended to develop rapidly liver failure because the TPN was not that good. Thank God now the situation is changed. Now it's almost unheard that in good hands a child will develop liver failure because we have better way to give the TPN. But back then the children were dying left and right. So we did actually living donor combined liver and bowel, and that 6-case series is the only one done in the world. Nobody has done it before or after. Another one, only the bowel. And I did it with an Italian, my dear friend Giuliano Testa. See, what I learned from Dr. Nigeria, you need to surround yourself by competent people. That's the secret if you want to do well. You cannot do it by yourself. You need to surround yourself with great people. And Giuliano is great. He's now in Dallas. He's the chief of transplant in Dallas. We are younger. So this is one of the patients that we took care. This patient is from Wisconsin. From northern Indiana. And I got a call, yes, this child, the local place doesn't want to do the transplant, he's in liver failure, has no bowel, can you take him? So, see, the problem is that if you wait for organ, the child's gonna be dead, right? So, he came with the mother, we worked up the mother within a day, and then we took him to the operating room. We did it in 2 stages. Please. So the first thing, we transplant the mother liver, you see, that's the segment of the left lobe of the liver of the mother, which we take out and put it in the child. So by doing that, we stabilize the child, because now it's no longer a liver failure. And then a week later, the mother is so generous that allows to go back and transplant the bowel as well. So that was an interesting era. Now, this is our result compared to registry. As you can see, we had an incredible degree of success, except one child that died for a lymphoma. Everybody else survived for at least 5 years. And go on. When we did, many years later, long-term outcomes, because we did this case in the early 2000s. Most of these children were still alive. Now you can go a little fast. You see, this is before and after. The child in the same toy. This is two mothers, one from Texas, one from Indiana, with their children after transplant. There was actually an illegal immigrants, the mother, but we didn't care. Go on. Of course, then these children will grow. This one I transplanted as a baby, it was not even 8 kilograms. Go on. And they keep growing, you see. They keep coming back to us. Now she's celebrating his 18th birthday. This one, 18th birthday. This one is the very first one done in '98. He's now 27 years old. This one is even taller than me and changed sex. Girl. So that was my first area where I focused, following the advice of Dr. Dasgupta. Then in 2000, I came to know that there was this new device, a robotic device to do surgery. And I was lucky that another Italian, I'll show the picture later, Mr. Bruno Pasquinelli, actually made a donation that allowed us to buy the robot. So we bought the 4th robot ever built from company Intuitive from California. And can you go back once? This is the paper that we published in 2001 of the first experience removing the donor kidney with the robot, a robotic donor nephrectomy, which we did the first one in September 2000, and to date we have done nearly 1,600 at the University of Illinois. So we did the first and the last. The last was Thursday. And the others are done by week 13. Well, this is a slide that shows when we reach 1,500. You see the difference is that instead of going through the flank, remove the tip of the 12th rib, cut all the lumbar muscle, you can make a small incision in the pubis, like a small C-section, place 4 small cuts for the trocar, and do the operation safely. So the donor has almost no pain, while the lumbotomy incision is incredibly painful. So I think yeah, I'll operate from. Just to have an idea why the robot is better.
Oh, there's a video.
Yeah, if I can play it. It doesn't. Oh well. That's okay. If it doesn't play, it doesn't play. But many people thought that we were doing just something for the. It's okay, it doesn't play. Go on. Just for the sake of publicity, personal promotion, which is not what we are about. Until we publish our first 1,000 cases in the Annals of Surgery, which is the main surgical journal, and we had an extremely good result. And what is peculiar is that we accept donor with high BMI. I will talk about high BMI later, but for your information, today in Chicago, 40% of the population has a BMI greater than 30. All Italian, you're skinny, but most of the people in the US are not. So we actually extend the privilege of donating to people that before were excluded. And then I recruited from Italy. He was the chairman of surgery in Grosseto, a small city in Tuscany, Dr. Piero Giulianotti. Piero Giovanotti has been one of the pioneers of robotic surgery. In this small hospital, he did more cases than anybody in the world. He did the first lung, the first esophagus, the first liver, the first pancreas. He really is a pioneer. And he's still our chief of robotic surgery to this day. So with Piero, we actually did something even more extreme. Please. We did the first full robotic-assisted kidney transplant. So the entire operation, as you can see on the picture on the right, rather than through a large incision in the lower quadrant, we do through a small cut to bring the kidney in, and then we suture the kidney with the robot. You see there's some picture there that show how we do it. The main advantage is that you completely avoid wound infection. If you get a wound infection, the result of kidney transplant decline. Let's see if we have probably the video won't play. But you see in the US, this is a 2024 slide. And you see Illinois is red. That means that more than 40% of the population has a BMI greater than 30. That is the level of obesity. In some of the southeast states, more than 45%. So, of course, if nobody in the US accepts a patient for kidney transplant with BMI greater than 35, you let 100,000 more or less people die on dialysis. So if you go on. Yeah, the video doesn't play, I'm sorry. I'll try once, but yeah, it doesn't play. That's okay.
See if I can do it.
Want to take a look? Anyway, the fate of patients on dialysis in 2025 is that if they stay 5 years on dialysis, 60% of them will be dead. Okay, so the survival is worse than, for example, colon cancer, breast cancer. So dialysis is a death sentence for many of the patients. While if you do a living donor kidney transplant, the life expectancy go up to 92%. If you do a cadaver kidney, 82%. So even a cadaver kidney more than double the survival compared to dialysis. So since nobody wanted to do the patient with IBMI, they were dying, right? But we started to reverse the trend. And once again, we were welcomed with skepticism, but the nice thing about medicine, you can then produce paper. And we produced a peer-reviewed paper in American Journal of Transplant of our first 239 robotic kidney transplant. Please. You may see, if you go back one, I want to show you something interesting. You see how many Italian names there are in that? There is a lot of Italian at the University of Illinois. That has been my pleasure to bring talented Italian to our university, right? That's the distribution by BMI. So 55% of the cases, the BMI greater than 40. We use the robot only for patients with obesity. At least the BMI must be 30. Otherwise, we do the normal operation open. And the percent that we do reflect the city of Chicago. As you know, it's 1/3 African American, 1/3 Latino, 1/3 white. And there's more African American because they have higher incidence of renal failure. So they are 17% of the US population, but 51% of the dialysis population. Wow. They have a rate of dialysis tripled. And you see, we did very well because our survival is the same as living donor in the US. Although our series was for 1/3 cadaver kidney. So not only we did this patient with IBMI, but we had result at 3 years of 93% still alive and well with the transplant. And that was the paper that changed the opinion of our colleagues. So instead of being skeptical, all the main centers in the country came to Chicago in our robotic lab to train, and now there are other centers that are doing it. So we sort of changed the perception. you see, when we start, this is a slide that shows you that our center, that is sizable, we do 310 kidney transplant a year. We did 53% of the patients BMI greater than 45 in the country. So now it's no longer the same because other centers came, learn, and they start doing it. So that has been the pleasure. We don't want to be exclusivity. We start even to combine the kidney transplant with sleeve gastrectomy, that is a common operation for obesity. And that's my first case. And you can see the lady not only has a normal renal function, but lost a substantial amount of weight. In fact, we did a randomized trial comparing patients receiving kidney transplant plus sleeve to patients receiving only kidney transplant. And the difference is that they both do okay, but you see, 12 months later, the people that get only the kidney transplant, from BMI of 45, they go to 47. The people that instead receive the sleeve and the kidney transplant, they go to 31. They're almost normal. So we do now routinely, anytime we have the opportunity for limb donor, we do the combined operation. We didn't stop there. We also did a simultaneous kidney and pancreas transplant for diabetic with the robot. Again, that's our first paper, 13 cases, we have done 40 now, largest series in the world. So in robotic surgery, we did all the first. Next, please. This one I cannot show you again, but maybe Arlene can solve the problem. Arlene is our administrative director of the department. She's an expert in computer. Go on. And in September 2020, we opened up this spectacular robotic lab that 17,000 square feet. It's considered one of the best in the country. In fact, all the major companies, Intuitive, Medtronic, use our lab as their national training center. In this lab, last year we trained 1,200 doctors from all over the country. So we sort of impose our leadership, thanks to Piero Giulianotti, thanks to the transplant, in robotic applied to transplant and other complex operations. Now, robotics starts small, but last year there were already 2.7 million robotic cases. At the University of Illinois, relatively small hospital, 400 beds, we did 1,700. So that's where surgery is going. Our prediction was that laparoscopy will disappear and everything will be robotics, and only people that cannot afford the robot will continue to do laparoscopy.
What's the advantage of robotics versus?
I wish I could show you the video. Maybe she will fix it.
Because I had robotic surgery done on my lung.
Right, it's superior because you see, first of all, you have a 3D vision as you look at the
I'm
robot.
still, almost after a year, I'm still having pain there from where the incision went in.
Did you do it at the university? You went to
Iowa.
Yeah, I mean, everything depends on the experience of the surgeon. I'm sure they did a great job, and you
Well,
are
you
here
said
to
he had
show.
10 years experience of using the robot, so.
Yeah. But you see, the advantage is the fact that you can do this complex operation, like resetting a piece of lung through tiny incision, right? Laparoscopic is very difficult, especially in patients with high BMI. So laparoscopic, let's say if you want to go down, you need to move up, right? If you want to go left, you move right. It's like operating on a mirror. The articulation is minimal. You don't have six freedom of movement. Robotic is like your wrist.
So it's more precise movements?
Oh yeah, I mean it's like the human wrist, except it can do a complete turn on itself. There is elimination of tremors because the system filters anything that causes a tremor. You can magnify up to 30 times simply zooming on the target.
Wow.
And you can also use all sorts of tricks. For example, we can use indocyanine green to see if something is well perfused, decide where to cut, where to spare, look if the kidney is well perfused with ICG. It's pretty much a revolution because in between the surgeon and the patient you have a computer, right? Everything you see is computer generated, everything you respond is a computer response. and in between you can put anything you want. For example, now we are doing tele-robotic surgery. Yesterday we operated from that lab to the Walter Reed Hospital, because now we can actually do that. The connection of the robot is through cable to this robotic tower. We can connect with ultra-fast internet, with optic cable. So we operated with a 50 millisecond delay in Chicago to Bethesda yesterday afternoon.
Wow.
So it's the way of the future. Think about rural Illinois, right? There are places that don't have surgeons. We can maybe operate it for them. Please.
Yeah, we're hearing a lot about the application of artificial intelligence, and it's to be making major breakthroughs in medicine. Are you doing anything with artificial intelligence, or what are your thoughts about the application of AI?
So we have actually a team of 3 PhD that work in that lab for application of artificial intelligence to robotic surgery. They've done already some remarkable first steps. For example, they can teach the robot to repeat the same step that the surgeon did. So if you do a repetitive step, maybe an anastomosis, you can teach the robot how to do it, theoretically. We have a system of image recognition whereby the robot can dissect along a preset line. And now we are working with Argon Lab. We have actually acquired, I think, 16 hours of their supercomputing. We are putting about 1,500 cholecystectomy video. We have a library of several thousand of videos, right? And we want to teach the robot to do the cholecystectomy, you see. So artificial intelligence will apply. One day maybe I will not be necessary, right? But then I'll be retired by then.
You mentioned computers, digital computers. How about quantum computing? Can that be used?
Well, you see, the quantum computer, the main merit is that we work on this supercomputing. I said that we hire 16 hours of the supercomputing conventional Argon Lab, right? If you try to actually place our video in the system, it will take months. So with our supercomputing, they take hours. Quantum computer probably will do the same in minutes. So of course, the faster the computer, the more you can do if it's a complex task. And this is Bruno Pasquinelli. That's the Italian man, he's builder, maybe some of you know him, that has donated to the university nearly $18 million over the years, including 10 million to build our patient center, 8 million to my department, he's my personal friend. He bought our first 3 robots. That's why we start early, because we had this man behind us, another great Italian, I think. In fact, no, our patient surgery center that is opening 2 years ago is wonderful. It's the Bruno and Sally Pasquinelli Patient Surgery Center. So we have in Taylor Street an Italian name on the newest building. So what's happened? If you do innovative thing and you do cases that nobody wants to do, your volume goes up, right? So we brought the volume up to 77 to 313. Next. And the University of Illinois is the largest program in the country for kidney pancreas. We do more than anybody in the US. It's not like we are a huge university. We just won technologically, you see. But diabetes care is something that I always focus on. This is another example of what we have done. We have done the very first, with Piero Giulianotti, and I did the transplant, the very first liver donor. We took the right side of the liver from a donor, transplanting somebody. Now it's done in other center, but we did the first one, I think in 2012, something like that. Yeah, this is just the first paper that we publish. Next. And that's the video. Unfortunately, the video today I didn't have much luck, but maybe Arlene will make it later. I want to close my presentation with another interesting field that we tackle. In this case, I think I can take some credit as the organizer and administrator and picking the right people. So, as you know, type 1 diabetes is different from type 2. In type 1, there's no production of insulin. It's most likely an autoimmune disease. There is about 1.4 to 1.6 patients in the US. There may be 10 to 12 million that have type 2, in which insulin is produced but not utilized properly in the periphery. So people have high sugar and all the complications. Now, the reason why the pancreas is so important is because inside the pancreas there are about 1 million islets, like the picture in blue. So those are pretty much a cluster of endocrine cells that produce hormones. The beta cell produce insulin, then there are alpha cell glucagon that actually antagonize the effect of insulin. Insulin drives the sugar down, glucagon drives the sugar up. I mean, there's insulin save people as being the great addition to the treatment, but doesn't stop the progression of complication. The complications are extraordinary. Number one cause of blindness in the US, number one cause of amputation, early coronary disease, premature death. It's a tragedy for this patient. So we actually pay particular attention to a subgroup of patients that have what is defined as brittle diabetes. No matter what they do, it's difficult to control, and the most important complication is hypoglycemic unawareness. What does it mean? It means that they don't feel the sugar going down. So the normal mechanism is that your sugar is normally about 100. If it goes to 80, the body reacts by producing glucagon that comes from the pancreas and rise the sugar. If it goes 70, the body starts worrying, so you produce epinephrine. But then, if you go below 70, you start having symptoms. You have headache, you faint, you throw up, you are nauseous. And what do? The diabetic feel that the sugar is too low, they drink orange juice, they take some sugar, and everything goes normal, right? Maybe somebody in the room is familiar with this picture, right? Well, these patients, 80,000 in the United States, do not feel the sugar go down. So what's happening is they may be driving, and all of a sudden the sugar goes to 20, they pass out, they crash the car. All the patients that we treated with the program that I will describe had at least one car crash, right? So it's a complication that unfortunately no amount of insulin pump can avoid. Of course, you can do pancreas transplant. I told you already that we have the largest program of kidney pancreas, so it's easy to conceive to do a pancreas transplant for a diabetic patient that lost the kidney to diabetic nephropathy. I forgot to tell you that that's the most common cause of kidney failure in the United States, diabetic nephropathy. Islet transplant was actually started in my other alma mater, University of Minnesota, by Dr. Najeri and Dr. Sutherland. And pretty much the idea, instead of transplanting the whole pancreas, which is a big operation with a lot of problems, we can isolate this cluster of islets and then inject into the liver. So the picture you see to the right is a rare picture that we got by chance, in which the central structure is insulin-stained cell inside the liver, the surrounding liver cell. So the advantage is that it's minimally invasive. I show how we do it. So the way it's done, we can take a cadaver organ pancreas that is not used for transplant. Maybe somebody older, somebody overweight. It doesn't matter for islets. Then we put in that particular device, which has an Italian name. It's called Ricordi chamber, because Camillo Ricordi, now at the University of Miami, invented the device. So the way it works, you inject into the pancreas an enzyme called collagenase that digests the structure of the pancreas, the collagen. This enzyme works only at 37 degrees, about 97 Fahrenheit, so the body temperature. So you inject the enzyme, then you put in the chamber, and you warm up the chamber, at which point the enzyme starts digesting the pancreas. And then we look at what comes out, and when we start seeing the cell, we stop the digestion. It's like cooking, right? You need to be precise. And then you purify. The islets are lighter than the rest of the pancreas that contain actually cells that produce enzyme to digest food, right? Amylase, lipase, they're all produced in the pancreas. Once it is isolated and we have a perfect solution, only islets, we inject into the liver. If you go to the next slide, I'll show you how. So what we do, we cannulate the portal vein, this vein that flushes into the liver through the skin in interventional radiology, and then we infuse the islets that then will sit in the liver, right? And then we pull out the catheter, embolizing the tract so the patient doesn't bleed. So in 1998, I asked the hospital administration to build a state-of-the-art islet isolation lab. I was already, the chief of transplant. I said, I want this lab. And they listened to me. That's why I stay here. They've been very supportive. Since we did not have the specification that the FDA would require, we built at the highest specification. It's a class 100 facility, still the only, and you will see, FDA-approved lab in the United States. It's a large lab, and the entire area is class 100. You can manipulate microchips in there, right? It means that a system of filter purify the air, allowing only less than 100 molecule larger than 100 micron. So the first step was to actually build the facility, because you see, although it's a transplant, for the US law, it's not considered a transplant, cell transplant. It's considered a biological therapy. Now that's make a huge difference, because then you need to go through all the requirement as a drug. You need to go through the FDA, the full-blown process. You cannot simply transplant. So in 1990, I got the facility. I didn't have the right person, but then 2 years later, I found the right person. Oseo Berotzer, Swiss national, that in 2002 was hired by me. Here I think we are in Puerto Vallarta in some meeting. And Dr. Oseo Berotzer is the man that did the work, coming at work at 4 a.m., going back home at midnight. So he's a very good transplant surgeon. Currently he's the chief of transplant in Zurich, Switzerland, but worked at the University of Illinois for almost 20 years. And we submit in 2017, we met the criteria for submission to the FDA. Very difficult. Usually these large multinational drug company, $1 billion, do that, right? So we do it at University of Illinois mostly by philanthropy, by NIH fund. We got $10 million in NIH grant for that, and about another $50 million from the university. We spent $35 million in this project. But Oseo Berotzer was so persistent. So we submitted in 2017 to the FDA, and they returned to him a comment that there were about 58 problems with their submission. Each of them required an enormous amount of work. Lesser men would have given up, but he didn't. He responded one by one until many years later, gone. We could actually show our success. The FDA knew it from 2017. This is the durability of the transplant. The C-peptide is a product of breakdown of the insulin. And if you have C-peptide in a type 1 diabetes, they cannot be produced by their pancreas. So we can find C-peptide in our patient, as you can see, in almost 50% 10 years after the transplant. Go on. What's more important is that this is the success rate after transplant. we had people that stay insulin-free for 5 years, 10 years. People that stop giving themselves insulin, people that stop having progression of the complication, and they can regain the ability to feel the sugar going down. That's fascinating, because we transplant also this alpha cell for glucagon. Next. And as you can see, their glucose that was out of control, the baseline become perfect. Even after 11 years, you get people with a perfect. Sometimes we need to do more than one transplant, but it's an outpatient procedure. So this is our result compared to historical data in the 3 largest trials ever done in the world. As you can see, we had a superior result, almost 70% of complete insulin dependence after a year from transplant. That's why the FDA said yes to us. They expect our lab at least 9 times. They drove the cost from 20,000 per preparation to about 55,000. Sometimes was irritating. In reality, at the end, we had a better product.
I have a question.
Please.
Is it okay to use this method as a preventive check? I mean, to prevent bad consequences
Yeah, you
of
see,
diabetes.
that's a great question. The problem is, for example, many times people call me up and say, I have a child, he's 7 years old, he's type 1 diabetes, why don't we do it before complication occur? Well, for 2 reasons. One, you don't know which child is going to get the complication. It's not difficult to predict. But the second most important is that to do this allogeneic transplant, we need to give immunosuppressive therapy. The same thing that we do for kidney transplant, right? So you need to strike a balance. You do only when you have a situation in which conventional methods don't work anymore. And to me, it's when they hypoglycemic unawareness, when they don't feel the sugar going down. Because in that case, they'll die not because of diabetes, they're gonna crash a car, right? So that's the only indication. We have other way, and we are studying our system. Maybe one day we'll give it to everybody, but we need to avoid the immunosuppressive therapy. I cannot disclose because it's a research that is ongoing, but we have a system that may avoid immunosuppressive therapy. In that case, then we can offer prophylactically. So anyway, go back a second. One more. In June 28, 2023, the FDA gave us the permission to use this preparation. So that's the only preparation approved in the country, and it's the only lab approved in the country. So we have already done some agreement with Georgetown, with Stanford, that we'll send ourselves, but the preparation is to be done in our lab, because theirs is not certified. And next. After a year, but dealing with insurance, because no.
The hope. But believe me, the new generation is from educated people, quite in a good economical condition, but extremely frustrated by the unfairness of our country for a while. I mean, people that were working hard to have recognized their ability, mission, that has been denied to many, many of us. So I'm not talking only doctor, other professional, other normal worker. I mean, it looks like if Italy lost this aspect, which is essential for living, to give a sense to our lives. So he's the best example of the new immigration, successful immigration, but it is too fair. I didn't want to talk about him, but believe me, I was there when he was there for a short period. We met about 26 years ago in the same hospital. And he's not only successful, he has been a inspirer for many Italian doctors and a lighthouse So yesterday I wanted to have to check how many Italian doctors are at UIC, many, in all important position, and I was shocked by very simple things. I mean, we think Italy is Rome, Milan. No, those people were coming from Perugia, Gubbio, from University of L'Aquila, University of Pisa, from all over part of Italy, which means Italy. So, good.
I have a couple of general questions, so we'll talk to you. One, how would you compare American medical training to Italian training? Two, how would you compare service gotten in Italy under national health care, or Canada, or France, compared to the so-called free market healthcare in the United States?
So I had the opportunity to train in both countries. I did full residency in the US, medical school, and I've been dealing with medical students for the last 30 years, right? So my answer is that medical school is now better. Italian medical school may be better.
Yeah.
What is superior in the US is the postgraduate training. That's what makes the American medicine special. The residency and then the fellowship. The ability of American medicine, on the example of the Mayo Brother, the Mayo Clinic, to specialize and train people that are formidable specialists for a very limited specific field, like I am for transplant. So that's the superiority of American medicine. In terms of medical care in Italy is regional. Center and North Italy have excellent medical care that costs nothing. South Italy not always has excellence, but in general, of course, if you go by life expectancy, Italy has 5 years more life expectancy for men and women than the US. And that is due to the fact that the US does not have a socialized medicine, right? So you have a high death rate in minority, in patients that are not insured. And we are lucky that we live in Illinois, that is a splendid state, with a 97% of patients insured, because that's a real state that takes care of the citizen. You go to Texas, they have more than 27% of their people uninsured. So that's impossible that you live to be 85 like they're in Italy, right? You die at 79 in the US as an average life expectancy. So I think that as Italian, I'm very proud of the system. When I left Florence, there were 20 people as intelligent and bright as me. It's not like I'm special. There are a lot of good people in Italy. I think here you can do more because the system supports you more. I mean, I couldn't do a $35 million research project anywhere in Italy, right? So the US has special training and, of course, the incredible amount of means. The philanthropy that in Italy is almost non-existent here is enormous, right? It makes a huge difference. So the US has something that Italy doesn't have it, but vice versa is true.
Thank you. I have another question actually.
About the follow-up of the patients post-surgical, post-transplant, how important is their location, where they can come from all over the world. I remember also a couple of patients that I sent in Chicago from Italy. But how do you follow after that? How important is in accepting a patient where they live? Is it important history, or you have a good network all over the world that you trust and can follow them?
If you're talking about a general surgery case like liver resection, pancreatic, after a month they go home and they are done and they have plenty of doctors can take. Transplant is different because they need the chronic immunosuppressive therapy,
Right.
and you need to ensure that. I've been doing a lot, many surgeons now do not do clinic. I was forced because I was chief of myself, right? I was division chief of myself. So I had to do everything. And I have a passion to actually follow up patients. I still do it. I still do it. And it's so important because transplant can be successful only thanks to a cooperation between the surgeon and the patient, and the nephrologist or hepatologist, whatever is the specialty involved. Because afterward they need to take the medication precisely. They need to come to clinic, they need to follow instruction. So unless there is compliance, there's no success. In fact, we exclude most of our cases for compliance issue. For technical reasons, we never say no. But if we are afraid that we will not take the medication, there is no point to do the transplant. Yes.
Do hospitals, universities, are they able to grow organs using that person's genes or DNA, for instance, something like kidneys, liver, so as to reduce the amount of rejection that takes place?
There is a field that actually one of the leaders is Italo-American, Dr. Vacanti from Harvard. So they've been trying to grow cell from stem cell for a long time. Now, if you talk about single cell, there have been success. For example, a company from Boston named Vertex has been able to generate insulin-producing cell from stem cell, right? And you can even use stem cell of the patient for cellular transplant, right?
Right.
If you talk about an organ, it's a lot more complicated, right? You take a kidney, you have a network of cell, blood vessel, glomeruli, blood goes in, you have specialized capillary that filter. It's not easy to replicate. It's not just generating a specific cell.
Right.
The difficulty is to generate everything else, right? And so far, nobody has really been able to do it.
Is it possible to use stem cells to repair organs that aren't too far advanced but are heading towards total?
There have been many tried. They put stem cell inside the heart of people with infarct, fail. They try to put stem cell inside the liver, fail. It's not as simple as you may think.
Well, I don't think it's simple.
No, but I mean, you ask in an important field of research, and medical research is progressing at a speed that is unheard of, right? 50 years ago, there were almost 35 years to double the medical knowledge. Now we double the medical knowledge in 8 months. In 8 months, the medical knowledge is doubled, you see. So it's, the sky's the limit.
Thank you.
Eli is working on islet transplants without immunosuppression.
I cannot comment on that.
Can you
I
say
just mentioned that this year.
roughly, I mean, how far in the future do you think this might be achieved?
We have done the first case a month ago. We can just release the information, but we did it.
What suggestion would you give to Italian medicine that Americans do better, and vice versa? What would you tell American medicine that Italians do better?
As I said, there are some features that are better. For example, the US, all the means available to us is beautiful hospital, costly OR. We have 7 robots at UIC, brand new OR, philanthropy that in Italy is underdeveloped. That is very empowering. So of course I would suggest get you a philanthropic donor like Bruno Pasquinelli, but there are very few, right?
Did Bruno have any personal reason for donating?
Yes, I would say that Bruno was just curious because he heard me over 20 years ago speaking Italian with my friend Giuliano. So he came up to us and said, I'm Bruno Pasquinelli, my family is from Lucca, he said. Going to be, he's from Pescia, which is a smaller town in Tuscany. But then over the years, of course, we have been able to help him and his family. He sent me a lot of people that needed medical care, which we did for him. And his favorite statement, he say, "I want to save life, including mine." So we took care of him in many situations. Yeah. Please.
Doctor, you have mentioned the cadaver, giving donors via organ donors through cadavers.
Sure.
When they're, can you please explain to this audience how important it is to donate their body after something happened, because this can save actually life. I don't think there's an awareness behind that, so this might save life.
That's a great question, and thank you for that. Of course, you see the organ donor that we are referring, most of them are brain dead donor. So their brain is unfortunately gone, or they're kept alive by machine, ventilator, etc. Those are the ideal donor, the brain dead donors. So not everybody that died could be a donor. But in that case, the US law allows us to procure the organ in the optimal circumstances. And those are the best donor, of course. There's also another class of donor. They're called donation after cardiac death. People that still have some residual brain function. So the law in the US imposed on us to, with the permission of the family, take the respirator out, let them go to arrest, and then we can procure the organ. To me, it's been always a practice that I despise, because it's like, you accept a gift and you spit on it. Right? If the family is willing to donate the organ, why don't we do it in the best optimal circumstances, right? Instead, because of an outdated ethical issue, we do this stupid thing to wait until the arrest, and then we wait 5 minutes, and really? But that's the law, right? So those are the two classes of donor, and the US has a good amount of donor. Illinois has a good amount of cadaver donor, very large database in the driving license. So I think our state, we can be proud.
Thank you so much. This was excellent. I appreciate it for all you do and the life-changing things you do. But I have 2 questions. First, we used to use the term for people like you as the gentleman surgeon. I don't know if do you ever hear of Dr. Robert Friark? He's certainly University of Chicago, University of Illinois, Cook County, and then came to Loyola. And he, like you, had this passion for his work. I mean, it was a life involved, he just was there 24 hours studying, researching, mentoring, developing his skills. But on the other side, he also had a passion for culture and tradition and what we would refer to as a Renaissance man, which is, I think, what we could say about you. With that being said, what happens today with the 80-hour work week, with the shift working resident, where I think the passion has kind of fallen away? I mean, how are you trying to mentor and develop? Because even I think fellowships are kind of going to the wayside a little bit when you're starting to look at the training of the residency. So how are you going to pass on this passion, this skill, this art and science that you have? That's my first question. The second was, what disease?
Let's answer one.
What disease state would be, I think you mentioned from trauma for a small bowel transplant, and I don't know if you said it was a congenital or a genetic problem, but are there disease states that you would transplant a small bowel for? And so those 2 questions.
I'll answer that is the easy one.
Okay.
Most of the bowel transplant is done what we call short bowel syndrome,
Oh, okay.
post-surgical, meaning for whatever reason people lose large segment of bowel,
Huge.
and then there is not enough for absorption. And if they have complication from parental nutrition, we do the transplant. There are some congenital, some due to dysmotility, meaning the bowel doesn't move, but that is the largest amount. Regarding the gentleman business, now I think you can call me a surgeon, and I love history. I'm a passion history. In some part of history, I'm as good as a professor, because that's my hobby and I study a lot. But the current generation is very different from us, yes. Now, I preface saying that since the golden age of Athens in the 5th century before Christ, they were all saying that the next generation will break the city, right? Eventually they did break Athens, but never happened. You know, the new generation somehow find their own role, and they continue to advance rather than go back. But I would say that what I don't like of the modern medical education is the fact that pretty much is based purely on information that are not retained. Nobody make an effort to memorize things, right? And I think that for a doctor it's very important, right? Especially if you react to emergency, right? If you have an emergency situation right in front of your eyes, you don't have time to check, Google or artificial intelligence, right? You need to have in your mind all the differential diagnosis, all the situation that could lead to that problem, and based on the finding, decide which one is the right answer, right? So to me, it's very dangerous the fact that medical students know anything anymore. I ask questions, I do round every Tuesday, they don't know much. They are fast in going to the internet and responding, but not good for medicine, not good for doctor.
Thank you.
I think for that reason, in Italy, at a young age they start doing interrogation when they're studying. So they're starting to have just where you talk to the teacher about the question he asked. Where here it's all paper and writing. It's nothing with oral presentation, so you're not using the memory to memorize.
Yes, still, when I came, we had the generation of residents, we were very busy, but my colleague knew a lot. My American colleagues were very knowledgeable. And I don't see that anymore. They're not, meaning that if you ask them a question, they will not know the answer 90% of the time, honestly. Then they will document themselves and so forth. But at the end of the day, like, the question previously asked, they specialize in a very limited field, become really good at it, and they perform anyway. So that's what I'm saying. It's difficult to pass negative opinion because the world evolved, and maybe now they don't need anymore to have the memory. But I know that if there is an emergency, it's better to handle than somebody that knows nothing handle, right?
Do you find other cultures, students to be higher caliber, better?
It's a planetary problem. They don't study anymore. Even Italian students. Of course, the difference is that the people that come to us are the best of the country that they come from, right? So you may have the impression that foreigners are better just because the best of the best come to the U.S.
My mom's boyfriend is a professor of biomed tech, and he said that students from Asia are much more serious and work harder than American students. I don't know.
This is certainly true, but also there is this bias, right?
Yeah.
People that leave their country to come to the U.S. are not the dumb one, always the best one.
This is true too.
Yeah, and they're vested in making the most.
I'll get to you.
I was impressed with that, your success rate with the high BMI and that kind of surgery. I'm just curious, what do you really attribute the success? Because
I
generally,
knew it. I was not inspired by imagination. There was a paper from University of Michigan that showed that obese or non-obese, if you have a wound infection after kidney transplant, your survival go down to 76 versus 94, right? And that regardless if you're obese or not. So the problem with obesity wasn't so much they're obese. Obesity increased the risk of wound infection. So if you have a BMI of 40, you have a 25% rate of wound infection. But with the robot, we eliminate completely wound infection. In 230, we had a single one on the trocar side. So that's why the patient did better. My hypothesis was that avoiding the incision, I will cut down on the wound infection, which happened.
so then my other question is, I totally believe in the robot and it's great for so many reasons. Do you feel like there's gonna be I've heard this through some medical people, that the young generation is gonna get so used to the robot that when they have to convert to open, they don't have that talent anymore?
Well, the problem was already present with laparoscopy, right? We have our chief resident that may have done 120 cholecystectomy, of which only 2-3 open, you see. So when my generation goes away, people will not know what to do and they have a difficult. But again, then the US has hepatobiliary surgeons, right? So sooner or later the patient will go to the hepatobiliary surgeon, which will know what to do.
What kind of surgery?
Hepatobiliary, people that specialize in liver surgery, right? But let's say standard general surgeon, he won't be able to fix a bile duct. He will have higher risk to injuring the common bile duct when they do a cholecystectomy. That's unavoidable, right? And that's the price you pay for the minimal invasive. Please.
Last question, about considering the shortage of donors, which anyway there is, not to deny, what is the situation of, at UIC particularly, of research about artificial organ transplant, bioengineered, in what field at USC they do research about this program?
Well, it's the same question that the gentleman asked.
Yeah.
Many try, nobody succeed. I'm sort of a practical strike in me. I always thought there was a long shot. I stayed away. There is, of course, another interesting area for donor supply, which is xenotransplant, meaning using animal, in particular genetically engineered pig, as a donor. And that one is a lot more promising. There have been already several cases, not successful, but at least breaching that. There have been 5 kidney transplant from this transgenic pig. There have been 2 heart. The results have not been good, but they show that it's feasible. So that's an area that may work.
Tell us a little bit about your work in matching transplants. I read that on the internet about a work that you did in getting people to, they can't give to their husband or wife, but you hook them up.
Yeah. It's called pair donation, meaning that, let's say, the simplest one would be 2 pair donor recipient, ABO incompatible, AB. You have another pair, BA, and you swap the donor. Yeah, we did it in many ways, and as done in other centers in the city. We did up to 6 pairs in the same chain. So it's a good system to transplant people that have either ABO incompatibility. We have also a system to do the ABO incompatible directly from the donor to the recipient, or they have antibodies. So we do that. It's called pair donation of swaps.
Okay, I'll have to learn that one.
I have a comment and a question. You were talking about the meritocracy, and I know the American Medical School hasn't always been that open to different people. My father's 83 years old, and he has several friends who are well-respected doctors back in my home state of Rhode Island. None of them got into American medical schools, and they all went to the University of Bologna and got their medical degrees there and came back, and then they all passed and they became well recognized for their training, and they actually still have a society of their colleagues. They get together, they were all Italian American that went to the University of Bologna. That was their entree into the field of medicine.
Yeah, of course, it's a close number game, right?
Yeah.
Like the University of Illinois is the 2nd largest medical class in the US. Indiana University has a little more. So every year we have between the 3 campus almost 380 students, right? It's a large, but it's 380, right? So you have 381, you're out of luck.
Yeah.
So then now many Americans would go to offshore school, Caribbean school. Some of them will go to Europe, go to Germany, to Italy. I mean, bright people.
Yeah.
It's not like the criteria for entry has always been a bone of contention because includes standardized tests called MCAT, but also characteristics that are openable, right?
Yeah, well, what
What's
those
the best,
gentlemen say is that they met all those criteria but still couldn't get in, and
Right.
came back and had a success. I mean, we're talking another generation back.
But now it's
yeah,
worse.
yeah.
Now it's worse.
Oh,
You know why it's worse? Because there's more need of doctors.
Yeah, yeah.
The US is looking to a spectacular shortage, especially of surgeons. And the number of people that come through the medical school is not enough.
Yeah.
There's in fact a lot of efforts of opening up alternative schools, right? Like osteopathic school. Watch India, they're going to have 2-3 new schools in the next 10 years.
Wow.
Because there is need.
And then my question was, I mean, this was fascinating presentation. Thank you so much. I'm just in awe of everything you did. What made you decide to become a researcher in addition to a doctor? Was that something you always wanted to?
I don't consider myself a researcher.
But you're an academic, though. I mean, you work in.
I publish my work,
Yeah.
but I'm a clinician. All my inspiration comes from patient. I tend to react to patient needs. I'm not a Please.
Professor, a very practical question. All this amazing advancement of medicine is, of course, thanks to your exceptional skills and background, but also thanks to this machinery, I mean, robots and new tools, etc. I hope Italy has something to do with it and not only China. Where do they manufacture these robots, this machinery, etc.?
I'll give you very interesting information. In the European country that has more surgical robots is Italy. Italy has been in the forefront of robotic surgery. And
the robot?
yeah, despite the fact that they had actually extra price tag because there was one distributor from Milan, so despite they were about 1/3 more costly, Italy has the largest number of robots. Because Italian surgeons are good, and then they have very good quality surgeons, and they all get. And Dr. Giulianotti was pioneer while in Italy, and inspired many to go for robotics. So Italy is in the forefront. There is even an Italian robot produced in North Italy, but the industry was originally only one company, Intuitive Surgical, from California. And they had the monopoly for 25 years. Now, at the end of the year, Medtronic, another company, will have a robotic system in place. We are actually their national training center, and we have already their robot that may be cheaper, although maybe not as good as the latest generation Intuitive. There are 18 different robots at different stages to be approved, right? Now everybody understood that that's the way to go. So there is enormous interest. There is a Chinese product that has been reverse engineered from Intuitive. It's not their robot. They just took apart an Intuitive robot and they did reverse engineer, ignoring any copyright and patent. And it works well. It's more or less like Intuitive.
Well, we can all celebrate Columbus Day, knowing that Dr. Enrico exists and has done so well for us and for all of his patients and for people around the world. Congratulations.